Welcome to Melanin Convos, a sisterhood of mom friends having relatable and unorthodox conversations while holding space for each other and amplifying Black voices. Hi, and welcome to Melanin Convos. I'm your host, Nikita, and today I have a special guest, Nicole Waite. She was my midwife, so this is a very special episode for me because I'm going to have a conversation with her about my birth story, my birth experience, being pregnant during COVID, and just all the things as it relates to Black maternal health. So hi, Nicole.
Hi, thank you so much for having me.
Thank you for being here. I know a lot of circumstances are happening, but I'm so happy that we were able to connect and at the right time too.
Yes.
So I want to jump right into my birth story. Mm-hmm. So I got pregnant March of 2020, like in the height of COVID. Yeah. Everything shut down. Mm-hmm. So I think I went about 4 months without seeing any health professional. Mm-hmm. And then I got a clinic, but I was feeling uneasy about the clinic. So I reached out to you. Mm-hmm. I think I should probably add that we went to the same church. So that's how I knew you, to reach out to you. Yeah. So I reached out to you and I had questions and you answered me. You offered me a lot of support and advice. And then you offered to take me on as one of your clients, which was like, yay. I was so happy, very excited. Mm-hmm. So my first question for you as a midwife working in Ontario, what is the difference between midwifery care and the more traditional OBGYN?
Right. So both care providers are care providers that take care of pregnant people, but the scope of practice is really quite different. And so you would have an expectation of a different kind of care. So I would say that an OBGYN or obstetrician gynecologist is trained as a physician, a surgeon, someone who has a highly trained clinical component to their scope of practice, whereas midwives do normal low-risk pregnancies. OBs are able to care for more high-risk pregnancies. Mm-hmm. They don't do any care of babies afterwards. Right. And they primarily do clinical care. There's not a lot of the social component that you might get with a midwife. So midwives are trained as primary care providers. So we're the most responsible person caring for someone having a low-risk pregnancy, like an obstetrician is the primary care provider for someone having a higher or low-risk pregnancy. But we also take care of a lot of the other needs people might have in pregnancy. So we spend a lot more time with people. So there's a lot more of a social, emotional relationship that happens for clients towards their midwives, as well as the primary care we provide newborns.
Right, and I think that's the reason why I was so adamant about having a midwife, on the fact that there was a lot more emotional support. It was a lot more holistic in the sense. And I feel like even in the midst of COVID, like a lot of my exams, my husband couldn't come with me, but at least when we had our sessions, I could FaceTime him. Yes. Even though he couldn't come into the clinic, he was still present because I could FaceTime him, where that wasn't an option when I would go to my labs and stuff like that. So I think that was my primary reason for wanting a midwife, just the fact that you would understand and give more of a holistic care. Yeah, that was my favorite part of the whole experience. Yeah. So why did you choose to be a midwife, and why would someone, or should someone, consider this type of care?
Yeah. So when I describe why I became a midwife, I really describe it as a calling. Okay. I was a teen parent, so I had a baby when I was 19. Okay. And I made a decision to have options in life. I was going to stay in school, and even though I didn't have a midwife at that time, it was only regulated in 1994, and my baby was born in 1993. Okay. I heard about midwifery through I think a friend of my sister or something, and as a new program. Right. At the university my sister had gone to, Ryerson at the time, now Toronto Metropolitan University. And so I thought, what's a midwife? I remember in the days of the Cosby Show, if people remember that Cliff was an obstetrician who had an office in his basement, in the homeless basement, and he took care of a lot of Black clients, Black women, and I just thought that was really cool what he did. Right. And so that was always in the back of my mind, even though I didn't really have an idea of what I wanted to do. So when I heard about there was a new midwifery program, university program, I looked into it more. And in those days, you just went the old-fashioned way to the library, and there was a little folder with maybe 2 pages about what a midwife is. And I volunteered. At the Association of Ontario Midwives Answering Phones in 1995.
Wow.
And that really got my feet wet in terms of like learning what a midwife does. And that from then I knew that's what I wanted to do. It took a few years for me to get there.
Right.
But once I actually got into the midwifery program, it was, I've been going through that ever since. So
nice. I actually didn't know that midwifery here was regulated in 1994.
Yeah,
I was
Ontario.
4 years old.
Yes.
That's over 3 actually.
Yes.
That's not that long ago.
Yeah.
And that leads into my next question.
Mm-hmm.
So there's a misconception. So when I was pregnant, I told my family I'm having a midwife. They're like, you are?
Yeah.
Why? And I was like, what do you mean why? Midwives were the first. That's who birthed, who do you think birthed your grandmother?
Yes.
A midwife.
Yeah.
But I had a lot of questions on is midwifery care covered by public health?
Mm-hmm.
Do you have to pay for it?
Mm-hmm.
What exactly are the regulations around midwifery care? How do you get it?
Mm-hmm.
Why would you choose it? So my question is, midwifery care is covered through public health care, but that's a misconception that people don't really seem to understand.
Yes.
What other misconceptions, myths, wives' tales that people have around midwifery
That's a good
care?
question. So I think one of the biggest misconceptions people might have is, one, that midwifery is. A lot of people have never really heard about what midwives do. Even in the healthcare system, and even where I work, sometimes people have no idea we exist.
Oh.
It's still a thing. But depending on which part of the world that you might come from, there may be misconceptions about what midwives do. A lot of people might think we're not educated.
Right.
Some people think that we only do home births. We also do hospital births. Some people have a sense that our training is not very robust in terms of when an emergency happens,
what do you do?
There's no help and there's no training.
Right.
And that couldn't be further from the truth. The reason the outcomes in Canada, particularly in Ontario where I work, is the outcomes are so good is because of the training that midwives receive. So we have training in emergency skills, newborn resuscitation, CPR, and that's ongoing training. So it's not it's a one and done kind of thing. It's every 1 to 2 years you're doing this ongoing training so that we can at least be the first responder to any kind of emergencies. And being in a robust healthcare system with access to emergency services actually makes the care safer. That's what makes it safe, is that we have that access. There's not a lot of the red tape. And because we're so fully integrated into the healthcare system, it's a fairly smooth transition when we do have to move someone from out of the hospital, if that's where they're planning to have their baby or laboring or birthing, to moving into the hospital. So it actually improves outcomes because of how all that cohesiveness works in terms of our relationships with clients, our relationships with the care providers and the hospitals that we have privileges at. Right.
And I think that really does speak to my whole birth story.
Yeah.
It's so great how you're feeding right into my questions.
Yeah.
So my birth plan literally went out the window. So I don't remember I really was gung ho. I'm gonna have a water birth, and I was gonna give birth at the birthing clinic downtown, not at home, but I was gonna have a water birth. It was gonna be so serene and tranquil.
Yeah.
And it was just gonna be amazing. And because it was COVID, I think at the time I was about 3 people or something along those lines. But then maybe a week later, before I gave birth, my blood pressure spiked, and then I had to do all these blood work and all this stuff and check my blood pressure, which I've never had to do ever in life. So that alone was just oh my goodness, this is just a lot.
Yeah.
And then I remember being induced the Saturday or the Friday. And then I ended up having an emergency C-section, which was, the furthest from what I was expecting to happen for us. Yeah. So in situations like that, and I think you mentioned the fact that your training is so robust. The fact that it had a team of people, so everyone knew what my birth plan was, what I wanted, the type of birthing mother that I was. So I think that was great, because even though you may have not been on shift, my secondary midwife was there, and she knew, she fell right in place, which was amazing. Yes. So my question is, how do you pivot in situations like mine, where like it's furthest from
the plan. Yeah.
So like quickly.
Yeah. So I think that speaks to our training, right? So part of what training means, or what training involves, is not everything goes the way you think it's going to go.
Right.
And I think that's one of the myths, actually, you were asking earlier about some of the myths that people might have, is that, you know, we're all like granola and Birkenstocks, and that we're just like, we just have this ideal, you know, you know, fantasy about what birth is. Not understanding that things can maybe not go to plan, and that couldn't be further from the truth either. And that part of our training allows and helps us to recognize abnormal. So one of the things our training prepares us for is when something starts shifting left from normal to drifting into the abnormal, and how to work with that so that we can manage it appropriately, and also to recognize when it starts to move out of our scope into something that's a little bit more than what we're capable of managing, and when it's more appropriate to start bringing other healthcare providers into somebody else's care, or consultation, even if it's not necessarily a transfer of care to a physician, at least consultation to get their opinion or a second opinion or around the management of that care for that person. So I think part of what collaborative care looks like is having care providers with different scopes, but collaborating with one another to provide the experience that someone's looking to have.
Right.
Even if it's not according to the plan, because ultimately you don't always get to pick the labor you get.
Right. Yeah.
You know, sometimes in the best of times, a labor is not normal, and we have to kind of manage it. But we do try to keep it as normal as possible, knowing that people have certain ideas of how they want their birth to go, and how can we keep it as close to that as possible, even if it's not the ideal scenario for somebody.
Yeah, and I would say, like, definitely for me, even though I end up having an emergency C-section, I feel like all the things that I wanted, like you and Karen were very good about like making sure I was still able to have like just time. Because I remember like when the OBs came in, they're like, okay, you're gonna have to have a C-section, and we're like, what? No. And like Karen was great at telling them, okay, like they need a moment, like can you give them a moment, and like just like advocating. She really did a good job. You guys did an amazing job of advocating for us. And I feel like that was like my biggest fear being pregnant, like not having anyone to advocate for me, especially like being in so much pain, not being able to advocate for myself. The fact that you guys were there to do that for me. And even like after I had the C-section and my son was born, and I really wanted like skin to skin, I remember like hearing her tell the nurse, okay, you can bring the baby to her now. Like, and just like prompting them to move quickly. So I feel like those are the highlights, but that was the reason why I wanted midwifery care, because I wanted someone to advocate for me, because I know that I probably wouldn't be able to advocate for myself. Especially in that type of moment. So, like you mentioned, depending on the where you live in the world, will really shape your experience with like how moms are taken care of, the services you receive, and even like who does not the birthing, but who is in the delivery room, right? So can you speak to Western medical practices and not necessarily being holistic in theory or practice?
Well, I think that you know, over the last few hundred years, there's been a real shift from birth in the home, which is where most people were born many years ago, to birth outside of the home, as well as a shift in our medical system, right? So there was a traditional way of healthcare, right? Before we knew about germs and we knew about, sanitization and all of those kinds of things. And it really shifted from a really community-based, knowledge-based, wisdom kind of base to, a very hierarchical way of providing care. So when we moved from, a more community-based knowledge to like more specialized medical knowledge, and patriarchal in a lot of ways in terms of men being kind of, becoming kind of the, I don't know what the right word would be, but kind of taking birth over, the lead in birth over, the century or more. It really took a lot of power away from the people having those babies, right? And so a lot of our instinctive knowledge and community-based knowledge and wisdom has really gone, pushed to the side, and in favor of a really hierarchical specialized knowledge base where a lot of knowledge is taken away from us and it's not shared in the way.
Right.
So it's very kind of, secretive, and you pay a lot of money to get a special kind of knowledge that only a certain number of people have. And if you don't know what I know, I'm the one that you trust because you don't know what I know.
Right.
So I think, giving people back and women back their power in terms of what their bodies are able and capable of doing, and helping them to believe that they're able to do that, goes a long way into empowering people in their birth experiences. And that's regardless of what kind of birth you have. You ended up having a C-section, but there's still a way to empower somebody who's having a birth that, even if they haven't planned it, in a way of bringing their dignity back, respecting their wishes as much as possible, advocating, because there's a lot of different interests that have come, been introduced with that hierarchical way of our healthcare system. A lot of times it's corporate, pharmacological interests first, and then the patients kind of somewhere, down the line. And, that has shifted the way that people think about healthcare, in that it has taken a lot of power away from people. So I think that, bringing some of that back, and also giving people knowledge, because a lot of what we do as midwives is give people information to empower them to make decisions and put the power back in their hands, so that even though we might be a guide to the side and doing the clinical care, the ultimate decision making belongs to clients.
Yeah,
and that's our goal as midwives.
And I definitely felt that, like, throughout all of our sessions. Even I remember we did, and I guess because we were downtown, and I noticed that a lot of downtown hospitals or clinics are either learning,
teaching hospitals.
Yeah. So I remember we did draw blood for a study.
Yes. So
and even me, I think it was preeclampsia that we drew blood, and then me being able to learn more about that. So I think there was a lot of learning in that experience, which I really did enjoy. So I know that I know here in Canada, we don't do the best job of collecting data based on race.
Yes.
And I know a lot of the things that we hear in the media of women dying, giving birth, or dying from preeclampsia. We hear a lot of either in the States or just in other places in the world. We don't really hear a lot about that here, or even some of the disparities that women face here in Canada. But they're very real biases, and they do occur here. Can you speak to some of the ways our medical systems continue to feed into those biases of Black women?
Yeah. So I think it speaks to some of the things I just mentioned in terms of a hierarchy of interests, right? So if you think about systemic racism and how racism is within a system, a power structure, where, people of color, Black people are disempowered, it feeds right into that, right? So if you are thinking of corporate interests or pharmacological interests ahead of the consumer or the patient in this case, or the client in this case, and then you add another system, racism into it, you're going to get those disparities, because there's no way that you can have that interest ahead of the person and expect them to come out on top. And so I think that some of the ways that people can take that power back is, one, I think seeking out care providers that are aware of those things, can actually respect your wishes, will listen to your concerns. I think in general, a healthcare system that provides for things like midwives that allow for not just clinical care, but other types of, social care, and accessible to people that are uninsured, for example, and other marginalized populations, you're going to get better outcomes. And what we see when there's less access, for example, in Canada, we mainly have a universal healthcare system. The outcomes are better. If you're going to have a system where there's a lot of privatized care, where, people who can afford better care will get that care, and other people will either avoid care or go without it, you're not going to get the outcomes. And also, if you have a healthcare system that excludes options for people are going to take their options where they can get them anyway, and you're going to get worse outcomes. So I think that not not legislating midwives or not supporting midwives to provide care to marginalized groups and to provide care in and out of the hospital. People will choose that regardless. But I think, you can see that the outcomes would be better if you have a system that's set up to provide an option for people who want to take another option, because they'll take them anyways. And I think that the accessible care component is also a big part of why outcomes are good, because midwives will care for people that are uninsured.
Right.
Whereas in a system where you have people that don't have that access, they're turned away, or they just won't access the care, you're going to get the poor outcomes that you see. We see.
That makes. So can you explain like how does the process work if you're an uninsured person and you go to like a midwifery clinic?
Yeah. Well, one of the benefits about midwifery care, at least in Ontario where I live, is that it's self-referral. So you don't have to go to another care provider to get a referral to a midwife. Somebody can email, call, and just apply for a space. Okay. And if there's space, then you're eligible. If you're a resident of Ontario, then you're eligible for care. We don't ask about immigration. We don't ask, about what your status is. Okay. If you have an address and you live here, then, unless it's really obvious someone is a visitor, then you're eligible for midwifery care, and you don't have to pay for that care. There are some components that you might have to pay for, but we have a special arrangement with the hospital I have privileges at anyway, to significantly reduce the cost of using the hospital if someone wants to birth there. Okay. Yeah. And I'm sure like labs and like that stuff, they may have to pay for. They may have to. There is a fund. It hasn't been around forever, but there's a midwifery fund. Okay. There's a fund that midwife clients can access, that would pay for consultation fees. So when physicians see someone to give their opinion, that would cover if they have C-sections, certain labs, etc. Wow, okay. I don't know how long that will be there. Hopefully it will maintain itself. But it's allowed a lot of uninsured people who actually want hospital births to be able to have that option, because a lot of the time we might get uninsured clients that plan out of hospital births because then they don't have to pay anything at all. Right. But they actually want hospital births. So we still want to be able to offer the choice of birthplace, which is one of the tenets of midwifery care, to people who are uninsured as well, and still give them the same full scope of what we can do, whether they're uninsured or not. Right. And so like, it still be comfortable. Yeah. That's important. Yeah. Exactly. My last question is, if you can remember like 20 plus years ago, because your daughter and I are like pretty much the same age, what made a huge impact on like the totality of your motherhood experience? Yeah. So I think I mentioned that the Cosby Show was an inspiration for the type of work that I do. I was a mother before I was a midwife, so that definitely informed the type of work that I'm doing. But in terms of like providing the compassion, and I look back on my own situation being a young Black mother, and some of the resources I really felt like would have been great for me if they were accessible. Right. That really informs a lot of the work that I do as a midwife, and also working with teens and other marginalized groups. Mm-hmm. Also the advocacy. I think that having someone that can be a voice when you don't necessarily know how to word it for yourself, or as you described, when people are in labor, they're vulnerable and they're in pain, and sometimes they can't always advocate for themselves the way they might want to. So motherhood has been a foundation for how I provide care to clients, in terms of the compassion and the way that I think about treating clients the way I would want to be treated, or would have wanted to be treated as a young mom. Okay. Yeah. So you mentioned you were a young mom. So as you were talking, I was like, did someone, while you were like raising your daughter, did someone like advocate for you? Yeah. Did you was that modeled for you, and like how to advocate for people to get like the best care? Because like I can only imagine you being 19, I believe you said. Yeah. I'm sure like a lot of people did not treat you well. I'm sure like healthcare professionals did not treat you well. So like, was that something that you saw modeled, or that you just like, I'm going to advocate for myself so that I can get all the things that I need for myself and my child? Yeah. Funny enough, part of what inspired me was so midwifery was regulated after I had a baby, but the obstetrician that I had at the time was actually one of the most compassionate people that I had involved in my life. I had met her some years before. And because I was a young mom, she took kind of extra care of me.
Yeah.
Even though I arrived at the hospital in very early labor, she said, I'm going to go do my clinic and then I'll be back later in the day to come and see how you're doing.
Nice.
Not knowing the baby was going to come a couple hours after she had left, but she sped back to the hospital. I don't know how she did it, and managed to just catch my baby without any.
Oh, wow.
She barely got gloves on, but she had her street clothes on. Like, she was just a compassionate care provider.
Okay.
And I always remembered that. So I always remembered how she treated me.
Right.
And I always remember like how I would want to treat or how I was treated, how I would want to be treated, even though I wasn't treated that well by everybody.
Right.
I remembered her, and she is a care provider. And as I became a care provider, I always remembered her in the back of my mind about the compassion that I felt from her. So I think that in terms of how I would explain it to people, it's not that I say, OBs are bad, midwives good. Right. Because there's a place and a great space for all of us there. But I think that the type of care that midwives can provide can address, I think, a little more readily the other kinds of needs that obstetricians just don't have time for. Like they do a lot of volume. Volume is care. Like, they have lots of folks that they're taking care of. Midwives have more time to do a little bit of a deep dive into the care because we have less volume than an obstetrician does. But there's places for both of us there, and I think that there's a great place, and I'm really glad we have access to the resources we do in a country like what we have. But I also think there's so much room for midwives and I think just better collaboration that would save lives. Like, I think it's just so simple to think about integrating midwives into care a little bit more and getting a more cohesive network of midwives working with hospitals, physicians, for people to make healthcare choices that they're going to make anyways. But why don't we keep people safe while we're doing it with a skill set, that people can have? And it would save the healthcare system so much money as well. If we're thinking about it economically, midwives save the healthcare system a lot of money. Yes. So I think overall, integrating midwives into the healthcare system overall, especially midwives of color and people who want to get into that profession, there should be that room and the support, governmental support for people to, join that profession because there's a demand for it, but also to get the word out and just help people understand that it's an option, because so many people don't actually know that we're here. Yes. So I will say midwives are here. Yeah, we are here. And if you want a midwife, you can do the steps or ask your GP about getting access to a midwifery clinic. Yeah, so that you can have the options that you want. And you can do a search. I know where I live in Ontario, if you Google aom.on.ca, that's the Ontario Association of Ontario Midwives, and you can do a search, or the College of Midwives of Ontario, and do a search for a midwife either by city, by name, or by hospital or whatever. But we're out here, and you don't need a referral from a physician. Yay. Yeah. Well, thank you so much, Nicole. Thank you so much. Yeah, like I mentioned, this is very it's special to me because 3 years later, having this conversation with you. So thank you so much. Thank you, my pleasure. And I was gonna say, where can I find you, but it doesn't matter because you know how to reach me. Yeah, but no one else needs to reach you. Yeah, they can't get to you. Yeah. So but thank you so much. I appreciate you. And I think that this podcast, what you're trying to do, is really a wonderful thing, because I think that a lot of moms, especially a lot of families, are going to benefit from just discussion, dialogue, and understanding, what care providers are doing and how to access those care providers and how to advocate for themselves. I think that's the other piece that you mentioned, is to just ask questions. It's okay to ask questions. If a care provider gets upset with the questions that you're asking, then maybe that's not the person for you. Yeah. So you keep looking, ask around, Google, search, because we're out there, and until you can get what you need. Yeah. Thank you so much again. You're welcome.